weeks. So we're going to have today, we're very fortunate to have Dr. Laskow talking to us about geriatric care and HIV. Next week, we have our coding changes update, which if you're like me and you haven't totally gotten a grasp of those, that'll be a good opportunity to get that sort of checked off. And then we'll also have some Bartlett Clinic updates from Sheila, and we're going to try and slip a case in the middle if we have time. And then March 3rd, we'll do another cases session. March 10th, we have the ID town hall meeting. So this meeting will be canceled. And then we have our much anticipated novel therapeutics session with Ethel, and I'll help out with some of the slides and stuff to go over some of the newer agents that are coming on the market. Then we also have an HPV vaccine session with Dr. Connie Trimble the following week, and then CROI updates after that. So lots of good stuff coming in March. But today, so to the main event today, so Dr. Thomas Laskow talked to us last year about the geriatric program, and is going to give us again an overview of their program and the resources that we might need to use as like all of us are experiencing the aging of our population. Mm-hmm. And then he's been kind enough to look at 2 cases from the practice and talk to us about some of the common issues that we face in care for patients with HIV who are getting older, like the rest of us. So welcome, and thank you so much for joining us today. And then I think that also he'll be open to talking to people who, if people have cases or want to discuss specific issues, I think we should probably have some time if people have other questions.
Yeah.
All right, great. So I'll turn it over to you. Thanks so much for joining us today.
Yeah, thank you so much for having me. It's great to be back. So, I think some point probably in these objectives just say we're going to talk about cases and how to use the Bartlett service and what we're doing here. So I think I probably included last time I spoke just kind of a general contextualizing of older adults who are living with HIV. And, a little bit more lines than I'd like, but in general, for every, for the general population, men and women with HIV, improving life expectancy. And if you can make through those first 2 years into your 3rd year and further on of treatment, then even higher life expectancy approaching the general population. And I don't think that I highlighted in our last talk, but a slide that is a little more complicated, but gets at some of the issues that'll come up today with these cases. And this is prior slide was kind of multiple cohorts in North America and Europe. Here, just looking in the Kaiser system, you can see over years, if you're a 21-year-old and you are a person living with HIV, and you can look at when you'll expect to encounter mortality or other comorbidities and how long until you would expect that. You can see that with mortality, that same trend of gradually improving and reaching toward the general population, whereas even coming to the more recent days, moving the needle on the comorbidity, so the other issues that an individual is seeing and when they would expect to see them, still for those who are living with HIV, not moving the needle as much on that. So some of these issues with complexity, dealing with other chronic conditions, and is what I think a significant portion of what we talk about today and what I see in the clinic. So just to briefly break the 4th wall here, we're going to talk about medicine. And I don't know if you can really break the 4th wall when you're directly addressing a group of people, but I do just want to talk about, kind of actually concretely the clinical consult service that we have here. And I want to do that by just thinking about the different models, ways that we could reach older adults who are living with HIV, and what we're happen to be doing at Bartlett these days. So, how this information got compiled is just 9 different practices where infectious disease clinic, primary care clinics were trying to gain some element of geriatric care and their experience with each. And there are other models, obviously, but 3 that they shared and had the most experience in was an outpatient referral. So this has actually existed at the Bartlett Clinic historically, where, referring out to the outpatient Johns Hopkins Bayview Geriatric Clinic versus a combined multidisciplinary clinic approach, which is really the heart of what Bartlett does and what we're working on right now, versus dually trained providers. So this would be you've become board certified in geriatric medicine and infectious disease, or some type of prolonged board certification but prolonged exposure to the other disciplines. So a lot of these are as you would expect, but I think it's just really, as we think about this, is worth kind of being aware of, and as we think towards the future, all of us together. So outpatient referrals, this is simple to do. The clinic exists and it's easy to start, but there are both barriers for providers in terms of remembering that there's other places that you could refer to, as well as patient barriers. I mean, the beautiful thing about the Bartlett Clinic is it's conceptualized as reducing that exposure to unfamiliar sites, kind of having to reinvent the wheel with trust, and also just basic transportation. For the combined multidisciplinary, so this is what we're doing. They're different models. There's some element of an embedded geriatrician. That's me in the current iteration. And then you could also have different, supports, other multidisciplinary team members, which is really the heart of geriatrics in general. And, frankly, we have things to learn from the care of individuals with HIV as well in that. So strengths, ease of access, coordination of care, and we do experience those. And the challenges are, a lot of places have tried this and had issues with financial sustainability. And then, even here, I think it's worth highlighting that, you're still two providers communicating about a patient, and the decisions you're making are often nuanced. So the need for kind of ongoing, continued conversation. And I'll highlight this actually very practically. If you do refer someone, which I'll talk about that more at the end, but this is generally the beginning of a conversation, and continuing to talk to each other, follow up, whether or not that individual actually needs to, see a geriatrician every year or whatever, even for a one-time visit, just kind of working together. And I'll just highlight as well that a geriatrician can make a recommendation, and the most often barrier is feasibility for a patient. So it's not like people receive these recommendations and are like, no, I refuse to do that. There's often, other insights that the provider has, or social situation. And then the dually trained provider, it has benefits similar to the embedded provider in this, not any kind of a formal evaluation, but the providers mentioned that people seem to really like this, and when in this situation that was evaluated, it was infectious disease specialists who received additional training in geriatric management principles, and then would, see patients as well. Now that was that particular was voluntary on the part of the infectious disease provider. So this also gets to, sustainability issues. And then the challenge, which is what we're frankly facing, is we don't have a lot of people who are going to go through infectious disease and geriatric care for specialization, and still, even in this most kind of convenient case, it can be hard to remember in a busy clinic with multiple complexity to refer a patient, and even in this, again, most favorable situation, but still additional visits and potential burden for patients. So these are the main modalities and the challenges, and we're doing, again, this multidisciplinary embedded approach. And kind of just getting, as we move on to cases, I'll just say, one principle that we need to continuously implement is working to get geriatric providers more familiar with the care of older adults with HIV. And then also what we're doing today, which is, talking to folks who are actively doing infectious disease and doing primary care as well, and finding ways to import those geriatric principles, regardless of whether or not, you think there's a need for referral, and even if you move on to a different practice where that might be more limited. Okay, so patient stories and clinical cases, and just again, Dr. Scully, thank you for sending these. And they just crystallize. I'll just put this up here once. Every time I talk a time about the 5 M's, these 5 domains that a geriatrician thinks about as we talk to these cases. And I think aloud, often this is the framework that I'm coming back for. It's not everything, but it's made to be something that any provider can use, and issues related to cognition and mood, mobility and function that'll come up. medications, being on the right medications, and how to navigate that complexity, multi-complexity, all the social and medical issues individuals face, which is, we know from evidence the burden of multimorbidity is higher for in general for individuals living with HIV, and then matters about. So this is a little bit of a kind of like the dark matter of geriatric medicine. I'm sure it'll come up and we'll come back to it. But if you don't hear about